and welcome to another podcast. Today we're going to continue with the medication and we're going to look at the different presentations of lignocaine that's available to us. Having said that, we'll move straight into lignocaine itself. 5 different presentations of lignocaine in which we can administer, and when looking through the PCCM, this is how the breakdown works for areas that we're allowed to use it. So lignocaine 1% obviously is mostly going to be used for our local anaesthetics, so it can be used for IO prepping site. Now it has to be noted here that whilst traditionally and recommended quite often with the administration of fluid through an IO site, it's best to give lignocaine through the actual IO, numbing the area before going with an infusion of fluid. Now that's you can also use it for bites and stings, obviously suturing, and pre the draining of boils and carbuncles. It is also very useful product if you're ever going to give an IM injection of antibiotics for whatever reason. It's a good practice to mix a little bit of 1% lignocaine with that. And it can also be used to remove foreign bodies from the ear. It can be quite traumatic, digging into the ear, removing insects, things like that from it. But if you use a couple of drops of lignocaine in the ear before removing foreign bodies, one, it actually stops the insects in their tracks. They don't move around as much. And 2, it takes away some of the irritation as well. Another one we can use is lignocaine gel. That in the PCCM is very limited in its use, and it's mostly used for children as a use for skin glue and even cannulation. Now lignocaine spray with phenylephrine is used for anterior and posterior nasal package. So when you're dealing with a patient that has epistaxis, you can use lignocaine spray in order to put a rhino tampon up into the anterior or posterior nasal cavity to help stop the actual bleed itself. So that is a very useful technique to have in your arsenal, especially if you have a patient on antihypertensive medications that hasn't taken them and you're stuck in the middle of nowhere with not many options up your sleeve. It can be a good technique to learn and even practice. Now the last presentation that we're allowed to use is lignocaine with adrenaline as a local anaesthetic. And finally, with the 10th edition, they've done something a little bit different. So all the editions up to the 10th edition have continued with the great myth and have discouraged all use of lignocaine with adrenaline in any extremities whatsoever. So you're not allowed to use it in fingers, toes, ears, nose, scrotums, peniles, the whole works. Not allowed to use it at all. And it is stated to use caution whenever using it in fingers, toes and earlobes. But it does specify that if there's any patient with or has a high risk of peripheral vascular disease, like your Renal's phenomenon or any patient with diabetes, it's best to follow the old practice of not utilising it at all. Now you could argue that the way that we're going to use it, we're not going to be suturing the ends of earlobes and the tips of nose, and we're certainly not going to be suturing scrotums or genitals together. But a big problem comes around when you have significant trauma to a finger and you want to use local anaesthetic like a ring block. The use of lignocaine and adrenaline is very useful in that case because it lasts longer. You can use a smaller amount of fluid within the area, and it also helps stop the bleeding. Now this story, for lack of a better term, has been around for a long period of time. I wouldn't be surprised if everyone has heard it or still says it, but a bit of a history look at where the whole myth came from. It came from a very long time ago, so back to the early 1900s or even the 1800s. They used to use local anaesthetics, and there was a lot of reports of gangrene happening from these anaesthetics when mixed with epinephrine. But the drug that they used way back in the early 1900s was procaine. It wasn't lignocaine. Now procaine was very acidic. It had a pH of 3.6, and if you sat it on the shelf for a long period of time, which was common practice in the time, it actually got to a pH of 1. And the injection of the acid was actually what was causing the finger necrosis, not the epinephrine. The reason they know that is because procaine itself, without the epinephrine, was causing gangrene just as much as the procaine with epinephrine. Now, if we look at the use of lignocaine with epinephrine, that has a pH of about 4.4, and literature right back from 1880 all the way up to the year 2000, there's been no cases of finger or toe necrosis after injection. And further to that, there has been plenty of cases where clinicians have accidentally injected themselves with pure adrenaline. So not mixed at all, just adrenaline, accidentally stuck their own finger and has given themselves. And this is particularly the case when we're dealing with auto-injectors like EpiPens. People have accidentally put it the wrong way, injected them into the finger, and so they've had high doses, 100 times stronger than what you find lignocaine and adrenaline in, and they still have no cases of necrosis from there. So whilst it's not overtly damaging to go along and say, don't do it, I often feel in medicine we have a lot of information that just isn't true. It's been founded from old science that's not quantified, and people have just sort of jumped on it from wisetail, and that's a very dangerous way to do practice. So always strive to have the most correct information and question everything, even what I'm telling you, and work to get a little bit more up-to-date information, and realize that if you do want to give lignocaine and adrenaline into a ring block or things like that, and the patient doesn't have peripheral vascular disease, you will now have a protocol in the PCCM that will actually back you up in the use of that. So it is a big step forward as far as I'm concerned in regards to lignocaine. Alright, let's continue on with a little bit of the pharmacology of our lignocaine. So its absorption, now when I talk about the pharmacokinetics, I'm talking about its use in local anaesthetic only, so topical and local anaesthetics, not its use as IV or anything like that, it's just local anaesthetic. So when used as a local anaesthetic, it has a peak plasma concentration of 1 to 5 micrograms per mil. Okay, so that's a pretty good amount of lignocaine that can be used. Now once it has that peak concentration amount, then it starts dispersing into the bloodstream. When it's in the bloodstream, it has a very high protein bound rate, anywhere between 60 and 80, which means systemic absorption is very probable. And with systemic absorption comes greater interaction and also other adverse effects that we'll look at. But like most drugs, the lignocaine, once it's broken down a little bit, once it's absorbed into the blood, then it will be metabolized by the liver and excreted by the urine. Now it has a half-life of 7 to 30 minutes. That depends on the area and the amount that's actually put in. But generally speaking, if you put local anesthetic in, you can expect to have the numbers for about 3 to 4 hours. Now its pharmacodynamics, lidocaine is a sodium channel blocker. Now in particular, it's actually a fast voltage gated sodium channel blocker. So what it does is, if we think back to action potential and conduction, it's the influx of sodium into the cell and the removal of potassium out of the cell that actually increases the resting membrane potential or the membrane potential in order to cause an action potential. Okay, so if sodium doesn't come into the cell via the sodium channels, then we don't actually have depolarisation and we don't have that actual action potential. And that is how it numbs the area. It prevents the action potential from even starting. Now, if you guys want more information on voltage gates and sodium channels and things like that, then I recommend you go back and have a look at the lesson on conduction. That lesson is focused around the heart. However, conduction, action potential, resting membrane potential is all the same in neurons as it is in cardiac tissue. So if you want greater understanding of how voltage gates work and its relationship between sodium channels and potassium movement, then I recommend you go back and have a look at that itself. Okay, when you're giving lignocaine as a local anesthetic, we need to be careful of hypersensitivity of that type of anesthetics. We also need to be wary that some patients are allergic to sulfides, and certain formulation of the drug contains sulfides itself. So it's just something to check the drug that you're carrying, and then obviously with the patient as well. Now, when you are using local anaesthetic and you're putting it into open wounds, or you're using it on the mucosa itself, there has been a lot of reports of significant systemic absorption when administered. So if you are using it into a large open wounds and you're using large doses, then you need to be more aware of adverse effects and more aware of interactions. Okay, now just keep that in mind when we start looking at adverse effects and then looking at the interactions of certain drugs as well. Because if you're using small doses as a local anesthetic or a topical, there are very few, if not no, adverse effects, or no quantified adverse effects to those particular ones, short of hypersensitivities or your idiosyncratic reactions. Once the lignocaine levels start getting higher and you start getting that systemic absorption, then you can move into the realms of lignocaine toxicity. So we need to be careful with how much we are giving all over the body, not just in one area, and what sort of area we are putting it into. Does it have a high absorption rate? Is it an open wound? Or is it closed skin? It makes a big difference when you're using lignocaine. The early signs of lignocaine toxicity can be your slurred speech, your altered central nervous system response. You can get arrhythmias and bradycardia. You'll see muscle twitching that can progress into seizures. Okay, so they're your big lignocaine toxicity signs to look out for. We'll have a look at a few other adverse effects with the different types of medications that we give when we look at the dose. Now, as far as interactions go, there are no interactions when you're using the safe administration, so the normal low doses of administration with the local or the topical administration of the lignocaine. As soon as you start moving up into those high doses, or you have an increased probability of systemic absorption and IV use, then you start moving into the realms of hundreds of possible interactions with other drugs. So if you have a patient that fits that category, I recommend looking up the interactions, asking the patient what drug they're on, and seeing if there is a serious or a monitor closely reaction that you will have with the drugs that they are taking. It's always a fine line with lignocaine of how much you're giving and how much the patient is absorbing. Now, finishing up with a few clinical take-homes, when you're doing local anaesthetic, so when you're getting ready for suturing or to excise a boil, you need to be aware of certain types of wounds come with particular risks. So one of those risks is tetanus wounds, so always check the vaccination status. We also need to be very careful of bats in particular and other animal bites. They may need to go away and get rabies vaccination. Do not believe the hype when people say there are no rabies in Australia. Whilst it's technically true, we do have a Lucius virus, which is basically a very close cousin of the rabies virus. Okay? Now, if we have indication to use local anaesthetic, it's usually done after a very basic wound clean. It doesn't represent a deep clean. That's generally done after the anaesthetic, so then you can get a bit deeper in there with irrigation and stuff like that. Now, 1% lidocaine is fine for most wounds. If you're thinking that you have to inject a large amount of fluid in order to achieve local anaesthetic, then you can have a conversation with the MO if you're carrying 2%. Just be aware that you are doubling the dose per mil. So just be careful with your doses. Warn the patient that as it goes in, it can hurt, it can sting, okay? But then they won't have any pain when you're cleaning and suturing as well. When you're injecting, always go within the wound, under the skin. Don't try to make new holes on skin that doesn't have a hole. When you're using lignocaine of adrenaline, use it for the right reasons. It will last longer and the adrenaline will cut down on bleeding. So if you're in a large vascular area or a larger cut, then lignocaine with adrenaline is a great medication to use. And last one, we'll just harp on a little bit more. Just be very careful with that fine line of safe doses versus high doses and patients with an increased probability of larger systemic absorption based on site and open wounds in which you're injecting the lignocaine into. Watch out for the early signs of adverse effects, because that generally means that you have a greater probability of lignocaine overdose. Okay, that finishes this presentation on lignocaine. But until next time, take care.